Welcome to Right Side of the Brain, the arts and health podcast created by Interact Stroke Supports. Our guest in this week's podcast is Amith Sitaram. Amith is the consultant of stroke and neurology at Glasgow University Hospital. He's previously worked in the stroke field at the University of Zurich and the University of Calgary. We're also joined in this podcast by my fellow podcast host, Megan Mackay-Smith. This interview was recorded during the period of the lockdown.
Great.
Amith Sitaram, a very warm welcome to Right Side of the Brain.
Thanks, Nijay, and thanks, Megan.
No, thank you. And I think on behalf of so many of us, Amith, we would like to thank you and all the other NHS staff who have been looking after everybody during this very, very difficult period.
Thank you.
If you don't mind, could we start at the very beginning? I've got a series of questions that I'd very much like to ask you. I'm sure Megan has her questions as well, and I'm delighted that my fellow podcast host Megan is with us today.
Thank you.
But Amith, tell us about your childhood. Tell us about your parents, where you were born, where you grew up, what your parents did for a living.
I was born in a very small city. In India, we call them as tier 2, tier 3 cities in a place called Shimoga, which is in a state called Karnataka, which is in the southern part of India. My parents were doctors. My grandparents were doctors. I never knew a life beyond that. I literally grew up during my holidays in running around in hospitals. So I had a very, kind of, if you can typecast me as saying that, oh, you're going to be a doctor in future. I was that kind of a child.
So when you say that your parents were doctors, your grandparents were doctors, if you'd suddenly turned around and said, "Mom, Dad, I think I want to be an actor," that would have that would have put a real spanner in the works there, Amith.
I to be honest, I never knew a life. I never met anyone whom I could be inspired by. So there was one point in my life where I had quite an inquisitive mind. So I wanted to be a scientist. So one of my teachers during my 11th and 12th class suggested that probably I should look at physics or biology because I was good in both. So I went and pitched this idea to my dad. And he sat me down. I mean, remember, this is 90s India. There was no, the computer boom was not yet happening. And you don't see very affluent people like the way the present India is, who are not doctors or. So he sat me down and told me, it looks fine now, but think 10 years from now, you come out as a physicist or as a biologist. What are your options? How are you going to make an earning? Do you think that you can sustain yourself or sustain a family if you want to have one? And if you're a doctor, you can set up shop anywhere. You can go any part and you can earn a living, and it's going to be a comfortable living. I was 16 and I thought that made sense. So
look, obviously, I come from the very similar cultural background to you, Amith, and it has such a. It probably has the highest status, I would say. Someone says, "I'm a doctor." Within Indian culture, my parents were very similar. They wanted their children to be a doctor, a dentist, lawyer, and that type of thing. Megan, have you got anything to say?
I was going to just say that you must have been the shame on your family then, Nijay, since you went into the arts. So I've definitely not known a pressure like that one at all. I was going to ask where you studied, Amith, and if you stayed in India to study or if you went abroad.
Getting into med school in India is hard. Depending upon which state you come in, we have to go through an entrance exam to get into med school. So there's, I think, about 150 to 200,000 people applying for 2,000 seats.
Wow.
So you have to be 95 percentile and above to get into med school. So I was pretty lucky there. I did my med school in Kasturba Medical College in Mangalore, which is again a coastal city in South India. And after finishing that, I did my general medicine training in Pushpagiri Institute of Medical Sciences, which is in Kerala, which is again a southern state. And after that, I did my neurology training in Kasturba Medical College, Manipal. And after that, that's the time where I was interested in stroke. I had amazing mentors. My professors were really good to me. I had two amazing mentors. One was Dr. S.N. Rao, who was probably the best clinician I've ever come across, who got me interested in stroke. And after that, it was Professor Radhakrishnan, who is an eminent epileptologist, neurologist. He's known worldwide, who really pushed me to know my capacities and spread my wings. And I worked in Kasturba Medical College, Manipal for a year as an assistant professor in the Department of Neurology, where I tried setting up a stroke unit. And then I realized there was so much of lack of understanding on my part, the infrastructure that is needed, what are the newer developments that was happening in stroke. So then I went to Zurich. I did 9 months of fellowship in interventional neuroradiology under Professor Valavanis. I don't know whether you're aware of him. He's one of the best interventional neuroradiologists. He's recently retired. And then after that, I went and did 2 years of fellowship in stroke from the University of Calgary, which is one of the best stroke centers in the world right now. And after that, I moved to Glasgow. Initially, I wanted to go back to India, but I moved to Glasgow because, I experienced, so much of difference in life. I mean, Nirjay will understand, when you're working in India, there's, it's kind of never-ending stream of patients after patients. It's neurology outpatient consisted of 150 to 180 patients in a day. And, you would go in the morning, finish your rounds, come back, sit in the outpatient. I don't think that I've had many lunches or coffee breaks. And you just go through the whole day. And at the end of the day, go back, finish your ward work and get home. During my training, I had both my kids. And when we moved to Canada, that was actually the first time I started getting to know my kids, what they like, what they don't like, how they are as persons, because I was so, involved with my career. So I decided that I needed some more time away from India, where I can do this 9 to 5 and spend some more time with my kids. And at that time, Glasgow was looking for someone with an experience in stroke because they were trying to set up thrombectomy services, and they wanted somebody with an experience in imaging of stroke and who have experience in thrombectomy. And I was looking for an opportunity outside, and kind of both happened at the same time. And here I am in Glasgow now.
Do you think that there's a fundamental difference in the proclivity of stroke, let's say in a country like India, as compared to the United Kingdom?
So, no, what do you mean by that? I mean, do you mean are there differences in terms of how people understand, or do you think that how people present?
Well, I think I was talking more in terms of one of the things that I have been told is that there is a higher incidence of stroke amongst, let's say, the BAME community. So is that reflected in a country like India? Is there a higher incidence of stroke as compared to other conditions in India, or are the statistics different?
I mean, it's a very difficult question to answer. One is because in India, we don't exactly have national statistics like the way we have here in NHS or, in my experience in Canada, because in India, the majority of the health services are through private sector, right? So it could be a small nursing home, it could be a small hospital, or it could be a big tertiary care setup. So it's very difficult to, sample those patients and say they're the true incident rates, because when you go to rural hospitals and rural areas of India, they may opt for traditional medicine like Ayurveda or some massage or something like that. So in my opinion, I think we never know the real true incidence of stroke in India. But I do agree with you on the point that yes, the stroke is definitely different in India in terms of we are as like genetically we are more susceptible for stroke because of there's a higher incidence of type 2 diabetes, there's higher incidence of pear-shaped obesity. And also, in my experience, the people who suffered from stroke were much younger compared to my experience in Glasgow. And we would see a lot of 50s and 60-year-olds, who are coming with stroke in India. Whereas in Glasgow, it's slightly higher cohort of age group. It's more of 70s and 80s. But in Canada, it was even higher. It was like 80s and 90s who presented with stroke.
Wow.
And the etiology is also very different. In India, we see a lot of infectious disease like tuberculosis and meningitis, and they themselves can cause stroke. And the tuberculosis incidence was so high, and have not seen a single tuberculosis related stroke in Canada. And I can't imagine seeing even one patient here in Glasgow. We see very less cancer associated stroke in India, whereas I see a very high proportion of patients with stroke who have undiagnosed cancer who present as stroke as the first symptom of a hidden malignancy, which is which is again surprising.
Again, you just said something there, Amith, which I just thought was really interesting. Why do you think, or is this a completely wrong perception? Why is the incidence of cancer so low amongst the Asian community? Well, is that because of anti-carcinogenic things that the Asian community eat in their diet, or is it a stereotype that's false?
I'm not sure, Nija. I don't know if I'm the right person to answer that question. I'm not sure whether the cancer incidence is lower in Asians or subcontinental population. I'm not sure about that. I think the only thing I can say is that it's probably the proportion. So if there is 100 cases of stroke, the cancer related stroke in that 100 patients could be 1 or 2 in India, whereas it will be like 10% in the Western world. The incidence of cancers, I'm not sure I'm the right person to answer because I've never worked in oncology, so I'm sorry, I don't think I can answer that question.
No, that's fair enough. Megan.
It's just fascinating to see which kind of health problems are more rife in other countries. And how you said obviously the tuberculosis, how that was almost non-existent in Canada. I was going to ask because you've worked in quite a few different countries. In terms of the rehabilitation for stroke patients in each country, what were the main differences? And are there any things that you saw abroad that you think we should incorporate into the rehabilitation in this country?
It's a good question, Megan. Let's start from India. So in India, one is that, there's manpower and labor is cheap, right? So, when we are offering rehab treatment to patients who are admitted with stroke, it depends upon which type of hospital that you're admitted in. So if you're admitted in this ultra modern, huge hospital tertiary care center in Mumbai or Delhi or something like that, the rehabilitation is going to cost you money. And you're going to get admitted. If you can afford that, it can be endless. As long as you have money, they're going to come, they can come home and they can give you the rehab treatment. If you're admitted in, let's say, a government hospital, recently it happened so that one of my relatives was admitted in India with an intracerebral bleed, and he suffered a hemiparesis. And they are from a village and they cannot afford any sort of rehab, and they're from a very poor background, and it's not able to afford this. There's no service. But if they move out and come to a district setup, and they can afford rehab, but from the government perspective, there is literally nothing.
Wow.
You have to be lucky to be admitted in a teaching hospital to avail some rehab, and it's as long as you're in the hospital. Once you're out, there is no rehab. Canada worked in a different way. In Alberta, where I was working, so once the patient gets admitted, we look at the patient and we decide what type of therapy the person needs, what is the ability of the person to carry out therapies. If somebody has dementia or they're doing very poorly, even at the outset of stroke, we don't think that they're very good candidates for rehab for multiple reasons. And if they're younger people and they suffer stroke due to many different etiologies, and they would be in a different pathway. So we had two different pathways in Calgary, where one would get more aggressive therapy. They will be in the hospital, and they were run by a group of physicians called as physiatrists, where they have an MD in physiatry, which is like rehab medicine. And those who are much more frail would go to a rehab setup where they will be admitted for a maximum period of 3 months. And once they're out, or at the end of 3 months, they have to go out because the new patients have to come in, and they will be picked up by the community stroke rehab team. And depending upon where they live and how much therapy they needed, they would be followed up by the community stroke team. In Glasgow, once the patient gets admitted in a stroke ward, so they will be looked after by the stroke rehab team, which involves physiotherapists, occupational therapists, speech and language therapists. And once they get out of the stroke ward, they go to a rehab ward, which is mainly looked after by geriatricians. And they have a rehab team where they look after them till they get discharged. And once they get discharged, either they go home, they go to nursing homes, and depending upon where they live, the community stroke, the availability or non-availability of a community stroke team depends on that. And I was once like, when you guys contacted me, I went and spoke to some of my colleagues in rehab team. So, it's for a finite period of time. Okay. So, because they cannot look after them because one, this lack of manpower, and, and it's as I told you, it's not forever, it's probably for 6 months or 8 months, and, it stops. If you ask me, like, what are the things, I mean, it's very difficult to comment on what kind of change we need. I mean, obviously, it would be really good if people can receive treatment for longer therapies, because people have benefited from treatment 1 year, 2 years, even after the stroke. But unfortunately, there's no manpower, there is no funding to provide long-term rehab.
That whole issue of feedback from stroke patients, who quite often say that doctors told them that after their stroke, the first 6 months would be the most important with regards to their rehab, and after that, that's sort of it. That's where they reach. Their rehab will then plateau. But we've met so many people who have managed to make decided improvements many years later.
Yes.
And so I wanted to know what your view of that initial advice is.
So as a stroke physician, I mean, I've seen people, whom I thought that they're not even going to make it when they initially present, and 8 months later they walked into my clinic, and I was surprised. Wow. So, like, it shows as to how little we understand about neuroplasticity and how neural networks develop. I usually tell them that, we can only go by statistics, right? When we are offering a treatment, for example, like thrombolysis, I tell them that, even with the best of treatment, best of times, 30% of the people go back to being normal, where they can look after themselves. The remaining 70% can go anywhere between 0 to 99% or 90% recovery. And where you go and where you stay, it's very difficult to tell now. Okay. And there have been, various studies which have shown that the earlier the rehab is more beneficial. It's not very early. Like, if you start rehab within the first 24 hours, it's actually shown to be worse because they can have other complications. But, the earlier we start the rehab therapy, the better they're going to be. And there are a lot of other factors that are associated with it. It depends upon patient's motivation, patient's family support, and obviously the financial support that they have, where if they can avail privately, all of those things make a big difference. And not all patients will benefit from long-term rehab because it depends upon the area of stroke. Okay, there are certain areas of brain where it's very difficult for the brain to reconnect, and they may not be able to get completely back to normal, quote unquote. But yeah, I mean, there are so many factors, like, where is the stroke? What is the type of stroke that they had? And how big is the stroke? What was the etiology of the stroke? Are they at risk of developing new strokes? Then coming to the therapy, like, when was the treatment started? How long did the treatment go on for? What were the types of treatment that the patient received? All of those things matter a lot. And I do believe, like, people do benefit long term. People keep improving because that's a natural history of stroke. You develop a damage to the brain, other parts of the brain start wiring up, start picking up some of the functions, and you start improving. But what is the percentage of people who still see these benefits after 1 or 2 years after the initial event? It's a very small portion of the population. And when we are designing services, like, we are trying to get the under the bell curve, the 95% of the people who fall into that would benefit from a set of therapy. And outliers, either those people who are on either side of the bell will obviously feel the pinch, because they're outliers, and it's unfortunate.
That's just to pick up on something you said a bit earlier about the lack of rehab afterwards in India. And then you're saying obviously in Glasgow, and it does depend on the family support as well. Would you say that there's a bigger responsibility on family to care for people after they've had an illness in India than there is over here? And kind of how does that aid or like hinder recovery?
The Indians' family psyche is very different. So in India, you cannot tell someone. I think it's better for the patient not to do anything, right? Like, if somebody had a big stroke and they're not going to make it, sometimes, whatever that you're going to do is going to be futile. It's probably harming the patient, making them more uncomfortable and things like that. But that's the Indian psyche. You can never tell them. And that has been my experience in outside India as well, in Canada and in Glasgow. And for them, they take it as it's their duty to look after their elders and parents, and they do it in some sort of a dutiful way. And Indian families are huge, right? I mean, you have like 100 cousins, and and they all are supposed to pitch in when there is a time of need. So there's always someone to look after, and many of the families are joint families or extended families. They come in, they look after. So it's a different type of setup. And when I say that the family support matters, is that, there are certain things that can be done by the family. Like, they're very minimal things. Like, for example, when somebody has had a stroke and they have a weak arm, just to know how to place the arm and how to keep the arm, to prevent it from getting locked up or developing complications of shoulder immobility. And we did a study where all that we did was, this was back in India, is to just tell the relative, the wife, the husband, the son, just to keep the arm in this way, or just to move the arm. And then the other one was left to just people getting rehab. They get rehab once in the morning and once in the evening, something like that. And those where we included the family, where all that we had to do was, just to keep the arm this way, so that, you don't get twisted, and, you don't develop complications of shoulder immobilization. And those people where the family was included did very well, compared to those where they did just receive only plain rehab without any family input. So I think that matters a lot. That's one in terms of physical, and the other one is the emotional aspect. Having a stroke, people don't realize is how much of the control over your life is taken away. Right? You have had a heart attack, and you go through hell of pain, and you think you're going to die, and then you come out, and you still have your mental faculties intact. You can still communicate. You can express your pain or relief or gratitude. And when you have had stroke, right, and you're locked, it's like I always imagine somebody where they cannot communicate through language, as if they're locked in a glass chamber. They can see people around them, they want to express, but there's nothing happening, there's no communication happening. And it's very scary, and it's very devastating to a person who was just living his or her life 5 minutes ago, and all of a sudden it strikes. And at that time, it's very important to have that family support, to be around you, people who can understand you, know what you like, what you don't like. I think it's very important. I've had these chats with people who have had stroke and who have recovered, and I casually ask them, you've gone through a lot. What was it that you missed the most? And they say it's like the taste of coffee in the morning, or taste of tea in the morning, or just to be able to eat their favorite food. And I always think, I mean, this was in India. I've never had this conversation here in Glasgow, as to how much people relate the smell and the taste to their familiarity of being around and all that. So they wanted that particular dish cooked by their mother or their wife or their husband. I mean, it was amazing. So I think having a good tight knit family support who can understand you, I think it plays a huge part in the recovery. Just to know that I have support and I can go through that, I'm not alone, I think it plays a huge part.
Gosh,
Wow.
that's really, really fascinating. Amit, I don't know if I'd mentioned to you that Interact Stroke Support, the charity that Megan and I both work for, we actually read at your hospital at Glasgow. The point of our charity is to take professional actors into hospitals and read to stroke patients on the hospital wards to stimulate memory, stimulate language, alleviate the depression that's so often associated with stroke, as you will know. So I just wanted to ask you if you had any particular views of the arts in relation to rehabilitation.
To be honest, Vijay, I mean, my main work is in acute stroke, right? And because of my work, I was always involved in acute stroke, and I've always had read about the influence of arts and music in terms of stroke rehabilitation. So I didn't know what existed in Glasgow. I went and spoke to some of my colleagues, and apparently Glasgow has a lot of art therapies for stroke patients, and I was pleasantly surprised. So they have, I mean, I'm talking about pre-COVID era. So they had art classes, they had painting classes, they had singing classes, and there would be people come in and have this day where they would come and sing, and like for people who are in rehab, they'll teach them how to paint. And I spoke to the rehab physiotherapists and occupational therapists, and I came to know that the people enjoyed that the most, rather than asking the physiotherapist to come and squeeze the ball 100 times, pick up the pin and put it in a box. And they would rather indulge in painting and trying to play an instrument or sing and dance, and they enjoyed it a lot more than doing just boring rehab stuff. And after you contacted me, and I started reading about what they're doing in terms of art and rehab, and I think it's a fascinating subject, and I think it has got a huge role to play, because in the end you want to make those patients better, not just physically, but even emotionally. I think art has a huge role in that.
My final question was in relation to Amit. I interviewed Professor Anthony Rudd, who was the former clinical lead in stroke medicine, and he said he made a very interesting comment, and I wanted to ask you about it. Where he said, "We're very good at functional improvement, such as getting people to the toilet or learning to walk again. But we're not very good at those things that make life worth living." And I just wanted to know what your opinion was on that. Do you think that is in a way a testament to having more arts-based therapies complementing the medical interventions that occur?
It's a very good question, Nirjay, and it's a very important observation. It shows. I mean, there is a generational gap, isn't it? Professor Rudd and I have a huge gap. He has seen so much more of life compared to me. I'm still young, I want to believe, and and when you're young, you don't have any boundaries, right? You're just looking at making this patient better, treating them as quickly as I can, and pushing them through rehab, because that is what is needed, because that's what the all the stroke studies tell you. Because see, when we are looking at why we are trying to make people walk or get up to the toilet, because when we are looking at an outcome, and what we term as a successful outcome is what we call as a modified Rankin scale, whether the patient is independent, whether the patient need care, whether the patient is bedridden. So we are all looking at that objective measure to say, yes, I've done a good job or not. And I totally agree with you. The larger question is lost in translation as to, is the patient happy at the end of the day? And I totally agree. And we don't know, right? I mean, what makes a particular patient happy? And I don't think we ask. I don't know I've ever asked anyone that question over the last couple of years. One is like, we are so busy. We're just rushing from one patient to another, and rushing to look after the next patient and trying to look at another scan and things like that. I think that humane touch is getting lost. I totally agree with you. And probably we need to revisit that question, sometime, when we are caring for patients, to ask as to what is it that you want. And this is exactly me coming back to that Indian psych. We look after a family, and we don't look after a patient. We never care what the patient wants. It's always what the family wants, what the son, the daughter, the husband, or the wife wants. And if we can show that the art and music plays a very important role in an emotional well-being of a patient, I think we should certainly look at it, in an objective sense, to see how best we can do that. And each person may have a different type of requirement, right? I mean, I don't know if everybody's art is everybody's cup of tea, because I was never good in arts. Sorry, Mirjay. So for me, like if I've always thought of this, like if you ask me at the end of the day, like what is it that you want? I want to be able to run in the ground again. I'm an Indian, so cricket is in my genes. So I want to play cricket again, or tennis again. If I can't do that, for me, life is not the same. Right. And I think those questions are completely lost for us in the present generation. And I agree. I mean, we should try to push more towards non-medical rehab.
Yes. Yeah. Megan, do you have any final questions?
But just obviously we do hear, from various sources about kind of the problems with the NHS. And you just mentioned that you're rushing from one patient to another. I mean, what is sort of the biggest challenge that you face on a day-to-day basis? Is it that lack of time, and is it just funding that would solve it, or is there something else?
Megan, this is a very
It's a huge
political
one.
question. Yeah.
Yes.
so, I so I mean, Glasgow is a whole different world compared to where I come from in Calgary. Calgary was amazing. It was a well-oiled machine even before I went in, and they were the best in whatever that they did. They were amazing. And when I came from there to Glasgow, it was a shock for me about the way the things worked. I mean, one is that the culture is different in North America compared to here in the UK, where there's a consultant-led service. So what it means is that the consultant is on the floor whatever time of the day or night, because that's the culture. The pay scale is different, and the way they work is different. There's no 40-hour work week limit. So you're working. I was on call 24 hours a day. At the end of the day at 4 a.m. in the morning, I just wanted to just tear everything apart because I was so frustrated. I couldn't get a wink of sleep. I hardly had time to eat. So, but the patient received really good care, but not exactly the best place for a resident or a fellow to be in. In Glasgow, we do very well in terms of, making sure that overall your work is balanced to 40 hours a week. But at the same time, I feel that there could have been more doctors, and there's definitely a lack of funding, and there's a huge lack of funding, because one of the most important treatment for stroke is called as thrombectomy. I'm pretty sure both of you have heard of it, where we go in and take the clot out of one of the major arteries in the brain, right? And Glasgow and Scotland as a country doesn't have it. Okay, and that's it's astounding. In India we had it, and people look at India as a third world country, and we had it in most of the major cities, but in whole of Scotland we don't have that service.
Gosh.
And for me, that is lack of funding, lack of people taking up this service, because I don't think they look at it as a good investment on their time, if you know what I mean. Like, you're coming at 2 o'clock or 3 o'clock in the morning, you're doing this and going back. I've spoken to people in Australia and in Canada. You're called out of hours to work and you're paid for that. And, in the UK, I'm not exactly sure how it translates, because I don't know how the finances work here. But what I'm told is it's not as lucrative. So people would rather not do that, rather than they would do another job or do something else which would keep them at home. So there's definitely lack of funding. I mean, if people can fund that service more, that makes a huge impact in stroke outcomes and stroke survival. There's also lack of funding based on rehab services. There's lack of rehab nurses, there's lack of rehab clinics, community stroke team. Depending upon which part of the country you live, I've heard people in the UK refer to this as the postcode lottery. You're in the right postcode, you get all the services. You're in the wrong postcode, you don't have anything. I mean, it's sad. It's definitely lack of funding, and so many things that you can improve in terms of stroke. So the bottom line is, yes, there is definitely lack of funding.
I feel like we should send this directly to the government, Nijay, for them to listen to from first-hand experience.
Yes, no, very much so. Although health in Scotland is the Scottish government's responsibility, as I recall. It's not the overall United Kingdom government. Listen, Amith, we've taken a lot of your time, and Megan and I are really grateful for you taking the time today and being part of Right Side of the Brain. Thank you so much indeed.
Thanks, Megan. Thanks, Nijay. It's a new experience, and I really enjoyed it. Thank you so much for the opportunity.
Oh, brilliant. Thank you.
That was Amith Sitaram. For more information on our work, please do visit our website at www.interactstrokesupport.org. And if you're feeling generous, please do click on the big red donate button. We very much look forward to your company on the next edition of Right Side of the Brain.